Thank you, host. Assalamualaikum and hello everyone. Welcome to today's CME. The CME series is proudly brought to you by the Selangor State Government through its Awareness on Mental Health Programme, or widely known as SEHAT. It is a collaboration with IIUM, International Islamic University Malaysia, and Malaysian Psychiatrist Association. I am Dr. Nur Faiza binti Muhammad Tohid, the moderator for today's CME, entitled Managing Depression and Anxiety at the Primary Care Setting. Even though this seminar is targeted to all the primary care doctors, but it is welcome for everyone who are interested to know in details about managing depression and anxiety, especially at the primary care setting. Before we get started, I would like to go over a few items. The session will be started with a 40 minutes lecture, and this session will be for approximately 1 hour. And you will have the opportunity to submit text questions to today's presenter by typing your questions into the chat pane. You may send your questions at any time during the presentation, and we will collect these and address them at the end of the presentation. But if you prefer to ask the presenter directly, you can use the raise hand icon on your screen. Ladies and gentlemen, depression and anxiety are common disorders in the primary care setting. They are associated with considerable distress and dysfunction. The management of depressed and anxious primary care patients can be complicated by the fact that these patients may lack insight into the cause of their symptoms and report only the somatic manifestations of their disorder to their physicians. Primary care patients may also be reluctant to accept a diagnosis of depression or anxiety or referral to a mental health specialist. Primary care doctors may feel they lack the time or the training to adequately address their patients' depressive or anxiety disorders. Therefore, CME will address the key guidelines for identifying, evaluating, and treating depression and anxiety to help primary care doctors to overcome this barrier. I would like to introduce our presenter, Dr. Muhammad Fazli bin Muhammad Isa. He is currently practicing as a psychiatrist and also as an addiction psychiatrist in Hospital Kuala Lumpur, HKL. He is the head of the Psychiatry Addiction Unit, PADU, Department of Psychiatry and Mental Health. Dr. Muhammad Fazli is a visiting consultant psychiatrist and addiction psychiatrist at Alaminda Specialist Clinic. He is also the head of program for the Addiction Psychiatry Subspecialty Program, Ministry of Health Malaysia. Dr. Muhammad Fazli has been appointed as a supervisor to oversee psychiatry specialist training for general and addiction psychiatry. He is also a supervisor for addiction psychiatry subspecialist training program. We are very delightful to have Dr. Muhammad Fazli with us today. I would like to pass over the session to Dr. Muhammad Fazli for the CME presentation. Please welcome Dr. Muhammad Fazli.
Assalamualaikum warahmatullahi wabarakatuh, and good afternoon to everybody that managed to be here today. Yes, I am very thankful to Dr. Faiza for her kind introduction of me, and I would like to thank you, the organizer, for inviting me to share. To share and to present some of the facts and also my experience in dealing with the management of depression and anxiety, so that can be used by those in the primary care setting in their day-to-day clinical practice when they bump into this kind of patients. So let me get some time to prepare or to share my presentation. I hope the host can allow me to share my screen, because there's an indicator, there's a pop-up on my screen saying that the host has disabled participant from sharing their screen. Can I be allowed to share my screen?
Try again, Doctor.
All right, now I can share my screen. Thank you very much, host.
Tak ada passion. Tak. Kenapa? Ada, saya dengar webinar je.
All right.
Sambil-sambil.
Okay, so I shall start here. Okay. I shall start here, and this will be the first of several webinars organized by SEHAT, UIA, and also MPA with the aim to empower doctors at primary care setting or primary care level in familiarizing themselves with the common psychiatric presentation or psychiatric illness before they refer these cases, if these cases need referral, to secondary or to tertiary care. So my job today is to talk about two of the most common psychiatric illness that usually comes to the care of primary care physicians. And I would like to start the presentation today by talking about major depressive disorder. We usually know major depressive disorder as depression. Okay, and sometimes when we try to make it more clinical, we will say that the condition this so and so is having is a clinical depression. But whether it is major depressive disorder in terms of diagnosis or major depression per se, or even clinical depression, as some like to put it, as depression itself is a mood disorder, very common, and it is more than just mere sadness. No, it is more than the usual sadness in terms of its intensity, in terms of its severity, and in terms of its duration. Although it is common, okay, if you explore it in depth, no, looking at how it started, how it progressed, and the complication that it causes, depression is actually a complex illness that comes with both physical and psychological manifestation, i.e. signs and symptoms. Unfortunately, in general, women are more affected than men, but what we are more concerned about the complication of depression is in terms of the risk for suicide. Okay, and not to forget, okay, there is also another kind of harm to self besides suicide in people who have depression, and this is harm in terms of neglect of self-care or personal capacity to look after oneself. So it is important to know and learn about depression because there's around 264 million people in the world who suffers from depression. In Malaysia itself, the prevalence of depression is between 8 to 12%, and it is a chronic, relapsing, and recurrent disease, similar to other common NCDs such as hypertension, diabetes, and other non-communicable diseases that we see in our clinical practice. Depression has its own relapsing, recurring, and also it can remit in its progress. Unfortunately, depression results in higher risk of early mortality because one, they can die from, or they can die from committing suicide, which we do not want to happen, or they can slowly deteriorate in terms of their physical health and medical status now, and they can also actually deteriorate by contracting other non-communicable diseases such as suffering more from the ongoing diabetes, hypertension, or even other terminal illness that they are suffering. So depression itself is a single largest contributor to global disability. Okay, and this has been proven many times through many small and large studies and research that have been done. In the primary care, okay, it has been noted that the prevalence of depression is around 6.7 to 14.4%. And what is a bit puzzling, or not to say, I think puzzling is the wrong word. What is intriguing about depression is in primary care is that the first presentation to the primary care doctors is in terms of persistent physical symptoms that has no clear cause. So this might give you an impression that depression is hard to look for. Okay, but I will let you know later in the few slides to come how to screen. What is the most simple sentence or question to ask to screen for depression before you move on to a more detailed assessment up to the level of making the necessary diagnosis. There are people, there are social circumstances, there are ways that people complain about their depressive disorders. And when we talk about people, okay, vulnerable individuals that are prone to depression include the old, the elderly, people who are medically ill, and also people or individuals who had just delivered the babies. Okay, they usually come with complaint of chronic, unspecific physical symptoms, chronic pain, okay, vague medical disorder, vague medical complaint. And what is interesting is that people, before coming to see us, coming to see the doctors first, they had Googled up their complaint, their problem, and they would come with a complicated chief complaint and history of presenting illness. But in terms of physicality and biological function, okay, they are depressed people who comes forward complaining about their loss of interest in terms of their enjoyable activities and their loss of interest in sexual activity. Many social circumstances can bring people to, can bring depressed people to see medical practitioner. It can be a positive, or if it can be a negative or even positive life changes. Some difficulties and challenges at home and work. Okay, financial complaint that has been one of the commonest thing being brought up to us since the pandemic, and also in the transition to the endemic phase after we endure COVID-19. And there's also people who are socially isolated, who are prone to get depression. Okay, one of the I think one of the important thing to ask people who come and see us is to get a family history or a background history of anybody, any blood relative that has a history of depression or other mood disorders. So how does depression happens? In psychiatry, we believe that there is no one specific cause. Okay, when in terms of psychiatric illness, okay, it can be caused by a combination of biological, psychological, and also social factors. In terms of depression, okay, when it is caused by biological factors, there is a combination of imbalances between the noradrenaline, serotonin, and the dopamine neurotransmitters. So the imbalances of these three major neurotransmitters is related to the monoamine hypothesis that was discovered back in the 1970s. Okay, as things progress, as research progressed, they had come out with with another hypothesis that is related to the glutamatergic pathway, and the glutamatergic hypothesis talks about the involvement of brain-derived neuronal factor, and also the capability of the brain to repair and the plasticity of the neuronal cells. Okay, and again, not to forget, okay, mood disorders, okay, such as depression, can be due to genetic vulnerability in the family. And as with other psychiatric problems, okay, we can also explore the possibility of psychological factors causing or precipitating the depression, and also the social status of the, or I would say the social well-being of the patient, that might combine and contribute to the vulnerability, or even contribute as a trigger or triggers for the depression to occur. The National Health and Mobility Survey 2019, okay, found that 2.3%, okay, found that the prevalence of depression to be 2.3% among Malaysians. And we shall not forget, okay, that the children and adolescents are not also spared from being prone or vulnerable and even getting depression themselves. Okay, 1 in 5 children are found to be depressed, 2 in 5 children are found to be anxious, and 1 in 10 children are found to be stressed, according to the findings from the NHMS 2022, 2020, if I'm not mistaken. Great. And one of my great professors in University Malaya, Professor Ng Chong Guan, had done a review of depressive had done a review on the research related to depression in Malaysia, and found that the prevalence of depressive symptoms, we are talking about symptoms in Malaysia, was between 8 to 12%. Okay, unfortunately, the reported rates were low, and depression were common to be seen among women of low socio-economic background in Malaysia, and also among those with comorbid medical illnesses. All right, so this is the gist of the presentation about depression. Okay, it is not wrong for us to ask, okay, how are people is feeling and how is their mood actually. Okay, so using this one question called Woolley questions, we can ask whether we can ask how, okay, or what have been bothering down or making them feeling down, depressed, or hopeless in the last 1 month. Okay, so the first Woolley question, okay, is used to assess the state of the emotion, the mood in the last 1 month. Okay, and the second Woolley question, or the other way, or the other question that you can use pertaining to Woolley question, okay, is by asking them, okay, whether they have been bothered or whether they have been affected, okay, by having little interest or pleasure in things that they used to enjoy. Okay, so if they answer yes to one, to at least one, okay, or both of the questions, then, okay, your screening for depression is positive. Okay, and if it's the other way around, it is negative. And this Woolley question is very sensitive, and the specificity of Woolley questions is quite acceptable. So following your screening questions about how they are feeling and about the state of their mood in the last 1 month, or even their state of interest in things that they used to enjoy in the last 1 month, okay, that screening question should lead you to explore more details to come to a possible diagnosis of major depressive disorder. Okay, we usually use either one of the diagnostic criteria. in the DSM-5 criteria, and this is based on the American Psychiatric Association publication, or we can also use the diagnostic criteria for depression stated in the ICD-11 or ICD-10. Okay, but to make things less complicated, I'm just want to present to you, share with you about making diagnosis of major depressive disorder according to DSM-5, okay, under or by the American Psychiatric Association. Based on DSM-5, okay, you need depressive symptoms to persist at least in the last 2 weeks. Okay, in the last 2 weeks. Okay, so you need that. You need it to persist in the last 2 weeks, and in DSM-5, okay, it states 9 depressive symptoms that you can look for, but you do not need all 9 to be present to come to a diagnosis of major depression. You just need 5, and out of these 5, okay, you must have either low mood or loss of interest. Okay, and it will be good if you have both of these symptoms. All right. So can I answer this call for a while? All right. Hello, tengah present. Sorry, bye. Okay. All right. Sorry. So you need to have at least 5 out of these 9 symptoms from DSM-5 to come up with a diagnosis of major depressive disorder. Okay. Any questions that you want me to, any issues that you want me to clarify up till now? All right, so I'll proceed further. So after making a diagnosis of major depressive disorder, okay, it is not so necessary to mention the specifiers, but just let me share with you that there are few specifiers in relation to the diagnosis of major depressive disorder in DSM-5, and some of it are things like depression with anxious distress, depression with mixed features. This means that the depressive symptoms is also mixed with a possible hypomania or mania symptoms. Now, depression with melancholic features, depression with atypical features. Atypical features meaning that if in the usual depressive presentation, you have people who cannot sleep, people who don't eat much, people who have reduced appetite. But in depression with atypical features, you find people who sleeps a lot instead of sleeping, having a lack of sleep. People who eat a lot as a way to run away or self-medicate their disturbed mood. And you have people who instead of having slowness in movement, i.e. psychomotor retardation, you have people who cannot sit still and who are having psychomotor agitation, right? So there are also a diagnosis of depression that comes with psychotic features, whether it is congruent or incongruent to mood. And lastly, we have a specifier in the diagnosis of depression that relates to depression that happens in the postpartum period. Okay. Okay. How do we know the severity of depression? Okay. If you have 5 or more symptoms of depression that you can elicit, okay, but those symptoms are manageable and there is minor impairment in terms of the social functioning, then the depression is mild in terms of severity. But if you have most of the symptoms, i.e. 8 or 9 symptoms of depression, and your patient have marked impairment in functioning, then you can give a diagnosis of severe depression. And it is easy to say it is a moderate depression when the symptom or when the symptoms is in between the mild and severe severity. All right. We do have an objective assessment of severity for depression. Okay, you can use Montgomery-Åsberg Depression Scale or MADRS, or you can use Hamilton Depression Rating Scale or HAMD. And this is an objective assessment with regards to the level of severity for the major depressive disorder. But in terms of day-to-day clinical practice, we seldom do this objective assessment due to the time constraint. And these two assessments, for example, okay, is more commonly used for research and study purposes. All right. So I move on into anxiety disorders. All right. Okay, I hope if you have any kind of question, you are welcome to ask me directly. Okay, or you can post it in our chat box, and I will try to answer it at the end of the presentation. Okay, so don't worry, but saying don't worry may be the best way to make someone or somebody anxious, right? So let's move on. Okay, relax, calm down. Okay, and we move on to the topic of anxiety and anxiety disorders. All right. So when we talk about anxiety, okay, not all about anxiety is bad. We need to be anxious. Okay, I need to be anxious for this presentation to be completed. I need to be anxious so that I prepare myself for today's session. Okay, and anxiety is actually our mean of survivability, because it teaches us to be adaptive and defensive against any threats. Okay, unfortunately, there's always the point where, okay, our defensive and adaptive mechanism of anxiety, okay, becomes things that can that can disrupt us or destroy us or damage us. And this is the time when the anxiety become uncontrollable and become excessive. It becomes excessive, and this is when it becomes a disorder. So when we are anxious, okay, and we are facing with any threats, okay, any uncertainties, we will be activating our fight or flight, our symptomatic system. Okay, and this can be triggered by specific or generalized triggers. Okay, and when the triggers happen, okay, there will be signs of anxiety that we can show. Okay, but at the end, when it becomes a disorder, it comes to a point. About the issue of us or them, and this is where our experiences in the past and our new experiences, our personality will determine the progress of the anxiety. Similar to depression, anxiety is a common mental health illness. Okay, and I would say personally, anxiety can be as complicated as depression. Okay, if you have several specifiers of depression, okay, anxiety has several categories or type of anxieties that I will share with you later in this presentation. Okay, to be cautious, okay, anxiety is not synonymous with stress. Okay, we know, right? You all know that you have good stress, which is the eustress, and you have bad stress, which is distress. Okay, but anxiety is not synonymous, okay, with distress or the bad stress. The prevalence of anxiety disorders is around 18% among adults, and the lifetime prevalence can be up to 30%. Okay, and any kind of anxiety disorders can be debilitating, personally, professionally, and also to the community. Right? When we talk about depression just now, we talk about the imbalances of serotonin, noradrenaline, and dopamine. Okay, when we talk about anxiety, okay, we shall need to know about the structure, the brain structure that is affected by the anxiety. So, and this include reduction of the volume of amygdala, okay, the volume of temporal lobe, and the decrease or the reduction in cerebral glucose metabolism at this location, plus hippocampus and thalamus. So, what are the symptoms of anxiety? You need to know, or you need to be aware that the symptoms of anxiety can be both physically and also psychologically. And when we talk about psychological symptoms, it can be rumination, thinking again and again and again and again about things that is not particularly important, or not or even not particularly distressing, or even distressing symptoms. Now, and people can be confused and frozen. Their thoughts can be confused and frozen when they are experiencing anxiety, particularly panic attacks or panic disorders. Many anxious people who have anxiety disorders have this anticipatory anxiety, and they keep on recurrently, persistently thinks about feelings of death or near death. As anxiety progresses, your threshold of anger, your level of anger slowly reduce, and you tend to be angry or irritable or easily irritable more and more. Okay, and that's when you are struggling with panic or panic disorder. Okay, then there will be a lot of fear, sometimes unnecessary fear that is affecting you. Similar to people who have depression, anxious people has disturbed sleep, and they lack in terms of their thinking about positive things or positive matters in their life. Again, okay, if that are all the psychological manifestation of anxiety and anxiety disorders, the physical manifestations of anxiety includes feeling dizzy, okay, palpitation, shortness of breath, muscle paralysis, weakness, profuse sweating, cramps, and also tremors. So there were a lot of cases that I saw in which anxiety symptoms were investigated to rule out organic causes such as hyperthyroidism, and people who experience shortness of breath and chest pain due to the anxiety are investigated as a possible case of ACS or myocardial infarction. But there are also people, successful people, mind you, high functioning people, okay, that are living quietly with anxiety. But behind the brain of these successful people, they live with the fear of failure and making mistakes. They feel the need to please others, and they are unable to control. They feel that they need to be in continuous control of the situation, and they can never say no to people's requests from them. And this cause, okay, and this led these high functioning people to be living, to continuously living on the edge, and some who are not so fortunate, okay, when they are living on the edge for a long period of time, when something can flip them, they fall down, and they fall down hard. Okay, So I told you just now that there are several specifiers of depression, right? And I have told you that there are several types and categories of anxiety disorders, and these are the type of anxiety disorders, right? Generalized anxiety disorders, panic disorder, separation anxiety disorder, specific phobia, agoraphobia, and social anxiety disorder. Right? We'll go through each and every one of these as thorough as possible. Not so thorough, I have to admit to you. Okay, right. Generalized anxiety disorder, as it names say, generalized. No? There's nothing specific about this anxiety disorder. There's nothing specific about why people are having these generalized worries. Okay, they keep on persistently worry about many unspecific things. They frequently ruminate, and but they'll tell you that they are not very sure what are they ruminating about. You know, and for people who suffers from generalized anxiety disorder, okay, there's usually no particular stressor, and it is usually related, okay, with person who have neurotic traits. So they can present to you sometime with history of experiencing blank mind. Okay, they'll tell you that their level of energy is low. They are easily fatigued. They are always on the edge, you know, easily continuously keyed up. They have sleep issue, and they have muscle tension. And again, when you ask them what is that, or what are the things that is running in your mind when they are experiencing this, okay, they cannot tell you something specific. They'll tell you they don't know, and or everything make them everything that's in front of them, everything that is currently around them, everything that is in the past makes them worry, okay, but nothing in particular, okay, can trigger their worriness. So from a generalized anxiety disorder, now we go to a more specific anxiety disorder, which is panic. Okay, panic is a symptom. Okay, and in terms of clinical presentation, you can have either a panic attack, which cause people to hyperventilate. Okay, has tachycardia or heart palpitation, aware that their heart is beating fast. Okay, you have people who have who are experiencing who are during this time, okay, also having nausea. Okay, they have chills or hot flashes. They sweat a lot. Their hands tremble. Okay, their hands will numb or tingles, and they become dizzy. Okay, and this is panic attack. If this is an episode, if this attack is an episode, this is an episode of panic attack. All right, this is an episode of panic attack. So when does it become a panic disorder? Panic disorder, okay, comes about when people have recurrent panic attacks and they start to anticipate, okay, when is the next panic attacks, and they live in this fear, okay, and worry about having the next panic attack. Okay, and this continuous worry, okay, is this continuous worry and of another panic attack, and the occurrence of another episode of panic attacks makes them allow the diagnosis of panic disorder to be made. Okay, so due to the panic attack and due to the panic disorder, they'll make significant changes in their life. Okay, to avoid the panic attacks when they are alone in a car, they will refuse to get out from their room, and they refuse to go to work. Okay, to avoid the panic attacks that will happen when they are in a crowded, jammed up place, no, they will decide to stay alone, no, and they refuse to go out from their house to get any supplies. They change from somebody who likes to do marketing to somebody who likes to order things from the phone or from the app. So these are some of the examples with regards to life that people will do, no, to accommodate their panic attack and panic disorders.
Sorry, doctor, another 5 minutes to go.
Oh, I thought we are ending at. Okay, all right.
Because we want to open for Q&A session as well.
Sure. I can do this. All right. So with regard to separation anxiety disorder, it is an excessively anxious or worry about separation from loved ones. And mind you, separation anxiety disorder can happen in children and also even in adults. But it will take, if we will give more time, about 6 months of having this separation anxiety disorder when we are going to make this diagnosis among adults. So separation anxiety disorder usually reflects underlying fragile or insecure attachment, okay, especially when they are far away from their loved ones. Okay, so just now the specific anxiety was panic attack or panic disorder. But there's a diagnosis, there's a category of specific phobias and also agoraphobia under the diagnosis of anxiety disorder. So this phobia can be phobia to crowded places, to narrow places, to high places, or even agoraphobia, in which it is a fear of crowded or fear of being in a marketplace. Social anxiety disorder is formerly known as social phobia. Okay, it is a marked fear about being assessed with regards to someone's performance, example public speaking, and they are fear about being humiliated, and the prevalence is around 7 to 8% in adults. Right? So 78% of individuals with major depressive disorder fulfills criteria for anxious distress, but they can have major depressive disorder with comorbid anxiety disorders. Unfortunately, if you have major depressive disorder with the anxious distress specifier, okay, you have a poorer prognosis, lower remission rate, and greater side effect from the medication. Treatment can be given psychologically, pharmacologically, socially, and even spiritually. And it does not necessarily have to be medication. And whatever medication prescribed to you, especially the antidepressant, are not addictive. Okay, so what we want to aim with regards to medication is to achieve response and to achieve remission following that. We want to make sure that people are stable during the as much as possible during the remission, and they can be categorized as people who recover, but mind you, relapses can occur because again, this is a chronic relapsing recurring condition. Okay, pharmacologically, the first line medication is the serotonin specific receptor inhibitor, which such as escitalopram, sertraline, fluvoxamine, fluoxetine, paroxetine. Okay, those are the kind of the usual medication that we can prescribe, and the second line medication. But what is more important is to optimize the medication in patient who fails the initial agent. So optimize it until use the medication up the dose until it's optimized dose before deciding to change or to add or to combine. Okay, so when you start medication, give the medication, that particular antidepressant, about 2 weeks or about a month before deciding to consider switching it, combining it, or augmenting it with another agent. So I would suggest that antidepressant be continued for at least 6 to 9 months after remission. Okay, but if you have a complicated cases, frequently relapsing cases, severe cases with suicidality or history of psychosis, presence of suicidal symptoms, then you may want to consider continuing the antidepressant or the medication up to 2 years before tapering it down, if you feel you and your patient feel that there is a chance that the patient can be not on medication. There are several non-pharmacological treatment that includes exposure therapy, cognitive behavioral therapy, relaxation therapy, mindfulness therapy, and also meditation. The easiest one is to do a mindful therapy in which you absorb or you be aware of the things that are around you, and that is to help you to calm down. Okay, and for people who are anxious, now they must be taught to identify what are the things they can control and what are the things that they cannot control. Okay, and when they can identify this, they must be empowered, to take charge of the things that they can control, and to manage the things that they cannot control. Right. Some people, some practitioners, some doctors refer depressed or anxiety patient, especially anxiety patient, to the clinical psychologist for graded exposure therapy. Okay, and the type of exposure can be in vivo exposure, imagination, virtual reality, or interoceptive exposure. And this exposure, graded exposure therapy, takes into account, the fear hierarchy, and you when the exposure level increase, then the patient will need to identify the level of fear that they are experiencing, and how can they manage their fear and also anxiety that comes with the increased level of graded exposure. These are some of the relaxation therapies that we can advocate to our patient, and it includes simple things such as practicing visualization, practicing deep breathing therapy, laughing out loud, drawing, reading a book, soaking in a warm bath, or even taking a walk, a jog, or spending more time in nature. You need to refer to psychiatric when you are unsure of the diagnosis, when you have high-risk patients who has plan of suicide, have active suicidal ideas, overtly psychotic, or severely agitated, and you can also refer to psychiatric services when you have doubts in your management, and you want advice on whether to switch, to combine, or to augment your medication. Okay, and we are also open in taking in referrals for cases that recur frequently in a year. Okay, who clinically who are showing clinical deterioration and who have self-neglect. So before I end, I would like to give my acknowledgement to these doctors who had helped me to prepare this presentation, and I am open to any question that I hope you have, so that we can make this session more beneficial to us. Thank you very much.
Okay, thank you, Dr. Fazli. I hope you would be able to capture the email address that Dr. Fazli have shown to us just now. Can you please show it again, Dr. Fazli?
Sure.
Or you can just type it in the chat box.
Yeah.
Okay. We have a lot of questions actually, but I would like to read up the major one. The first one is how to do simple CBT at primary clinic with very limited time.
Very good question. Okay, so maybe you want to do a modified CBT instead of a simple CBT, because the non-pharmacological approach is CBT based actually. No? And a simple or modified CBT would be like listing the problems that the patient is having, then making it into hierarchical from the easiest to the most difficult, you know, and then identifying what can what can be done for each of the issues, you know, and the pro and the cons of the intervention for each of the issues or problems that had been listed down. For patients who have anxiety disorder, as I mentioned just now, you can ask them to list down things that they can control, that things that they cannot control, no? And how to empower them to do more for the things that they can control, and what coping mechanism or coping skill that they can use to manage things that they cannot control when those things happen to them. Okay, so these are some of the simple so-called modified CBT that can be done in a busy clinic. No? Because when you talk about CBT proper, it needs to have sessions, it needs to have contract, it needs to have homework, blah, 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 blah. And I do understand that it may not be suitable in a primary care setting.
Okay, another question. After Woolly screening, what are the screening tools to use, especially in primary care setting? Is DAS enough or should proceed with PHQ-9?
All right, screening questions or screening tools are for screening. Okay, so one screening tool will be enough. Okay, if the answer to your screening tool is positive, then you proceed straight away to a detailed assessment. I'm talking about eliciting the 9 depressive symptoms that I have talked earlier, and that should assist you and allow you into making a diagnosis of major depressive disorder. Bear in mind that major depressive disorder or clinical depression or major depression, okay, is more than a mere sadness. Okay, it's more than the usual sadness in terms of intensity, severity, and its time period. So if your screening is positive, move on into assessing in details about the symptoms according to the diagnostic criteria.
Okay, we move on to another question by Monisha Chandra. Should we treat mild to moderate depression with combination of psychotherapy and antidepressants, or would CBT suffice at first visit?
For mild severity of MDD, okay, non-pharmacological treatment is usually enough. Okay, it's usually enough. If you want to add in symptomatic medication such as benzodiazepine just to help the induction of sleep, be my guest. But it should be in control. It should be prescribed and it should be explained well. Now that's for mild level of MDD. You can treat with non-pharmacologically. Okay, but for moderate and severe, okay, there should be a combination between the medication and also psychotherapy. Okay, that is a must. That is a must. Okay, and medication can be antidepressant alone or antidepressant with a combination antidepressant and a combination of benzodiazepine, short-term benzodiazepine.
Okay, another question. What is the next best step if we meet patient fulfill criteria for depression or anxiety but can't accept the diagnosis and they refuse treatment? A lot of phenomena like this, like it's happening in the denial state.
Yeah. Number one, it is good that the person had reached your doorstep, your clinic doorstep, although they but I understand the challenges of people not wanting to take in or accept the diagnosis. So what I usually do, okay, is call in the family separately first. I call in the family separately, okay, and I explain it to the family, and I see them again. I see them again together. So when the family, usually when the family is briefed and understand about the diagnosis, okay, the family become my medium to influence the patient, to make the patient understand about the diagnosis. Sebab it is very common that we are outsiders from their family. They do not want, or they are reluctant to believe in us, because we just saw them in the last 15-30 minutes or even 1 hour. How can that trust be built that fast, right? So we use people who they trust, okay, as our medium to influence them to accept the diagnosis.
But what happens if the parents, I mean the caretaker, refuse? Usually it happens for the teenagers, kan? Then it reflects on their parenting skills. Then the parents refuse to accept the diagnosis.
All right. So, repo and trust is a must. Okay, repo and trust is a must. Whether they want to take up the diagnosis or not, itu sudah jadi the second thing. Okay, but if they trust you that you are not playing hanky-panky with them, just making up the diagnosis, okay, they will stay or they will want to come back. And for those people who want to come back for another session, I ask them to bring somebody that they trust, be it a friend, be it a partner, or be it their teacher, or be it their neighbor. So again, I use people that they trust, to talk to the family, to the parents, and even to talk to the patient. That's how I go about with my challenges lah.
Okay, another question from Nazmi Razali. Which SSRI should we choose for breastfeeding mother with MDD who complains of drowsiness on sertraline?
All right. Ini advanced level question. Okay. So, all SSRI can be used. Okay. If they are having problem, let's say with your sertraline, you can change it. You can choose escitalopram. Escitalopram is a good choice for people, for ladies who are breastfeeding or even pregnant ladies.
Okay, another question from Elaine. How long shall we continue antidepressant for anxiety disorders?
All right, 6 months to 9 months will be just nice for a first episode. Okay, 6 months to 9 months. Okay, but as I said just now, if you have complicated cases or cases that have that relapse frequently in about a year, okay, cases in which the sociological aspect and the functioning is greatly affected by the anxiety, then you may consider extending the antidepressant up to 2 years.
Okay, another question for from Dr. Ain Sabrina. For teenagers, is the diagnosis of MDD and GAD is the same with adult DSM criteria, especially teenagers with underlying ID or ADHD that was diagnosed since childhood?
Okay, the diagnostic criteria is the same. It's just that the presentation and the way we elicit those symptoms, those diagnostic criteria may differ. That's all. The symptoms are almost the same. Don't worry about that. It's just that if I can use another cohort of patient, medically ill patient. Medically ill patient are always low on their energy level, especially those suffering from terminal illness like cancer and whatnot, right? So we cannot use a low level of energy as a diagnostic criteria. Okay, so that we must explore other symptoms. So if you look back to the question that is asked, adolescent, adults, they have the same diagnostic criteria, but the difference is in terms of, how do I say this? The difference is in the terms of the intensity and the way the diagnostic criteria is presented. I hope I made myself clear.
Okay. Back to the statement that you have mentioned earlier, that is to try to get a family member or somebody that the patients trust. There's another question for that. What if I can't get hold of a family member?
All right. So this is where I think provision of information in the past or even currently we are distributing pamphlet, right? So you can provide them with this information. Now you can show them websites that they can use to read about depression and anxiety. You can introduce them to online support groups, that they can join just to listen to other people's experience. So and then because of the trust and rapport you build with them, okay, if they come back to you, then you can discuss about the information that had been given to them, right?
Another question, there are really a lot of questions, Doctor. You're okay with it?
Okay.
All right. With regards to time frame and clinical presentation, would you tell us about dysthymia versus MDD?
Oh, okay. Like I said just now, MDD needs 2 weeks, at least 2 weeks of time period to make the diagnosis. Okay, symptom must be in 2 weeks lah. Dysthymia or persistent depressive disorder (PDD) is another diagnosis. This is where the depressive symptoms, is at the low intensity, okay, and it's continue for about 2 years, right? So that's the difference. Okay, the intensity in PDD, okay, is not as much, but in PDD there can be episodes of MDD. If you want to make your life more complicated lah, right? Focus on MDD, okay? Because in PDD there's a lot more things that will come to the surface, I tell you.
If PDD, just refer to psychiatrists.
Yes, no problem. Yeah, it needs more than medication and CBT.
Okay, yeah, sure. Okay, another question. Do we give medication antidepressant for patients with separation anxiety disorder or specific phobia and agoraphobia and social anxiety disorder?
Okay, all right. Again, if the intensity of the symptoms, impairs the function, okay, then I would want them to be on medication. Okay, but the bulk of intervention that will make a greater difference, is to teach them the non-pharmacological skill or intervention. Right? Okay, so you can do psychotherapy. Okay, you can do CBT. Okay, if you don't know, you can refer them to the clinical psychologist for CBT, for graded exposure therapy. And as an example, doctors who have problem, who have anxiety going to work. Ini bukan mengada-mengada punya cerita. Okay, ini bukan mengada-mengada punya doktor. They do have anxiety disorder going to work, our intervention is to introduce occupational therapy, to guide them, to help them in their graded exposure, to help them in their problem solving skill. That makes a difference. Okay, the medication will help to stabilize the depressive symptom, the anxiety symptoms, but the answer to make that change, to make them improve, to make them progress, is the non-pharmacological intervention.
Okay. Another question. Should we add benzodiazepine when starting SSRI for MDD? In primary care, we only have short-acting like alprazolam and clonazepam.
Yes, of course, you can add in benzodiazepine. Okay, but benzodiazepine is just a supplement. It's just an assistant to the antidepressant. Okay, prescription of benzodiazepine should not be for too long. Some guideline like the NIST guideline advocate prescription of benzodiazepine only up to 6 weeks. You can use alprazolam to induce the sleep. Okay, and you can prescribe your antidepressant also at night when the patient is going to sleep. Okay, clonazepam is long-acting. It's a long-acting benzodiazepine. So clonazepam, yes, you can produce also. You can prescribe also to induce the sleep, but the problem is they can have the carry forward sedation to the next morning. Okay. To re-emphasize my answer, yes, you can add in benzodiazepine to the antidepressant, but the benzodiazepine must not be for long term, and I advocate prescription of benzodiazepine for less than 6 weeks.
Okay, this is the last question. Okay, shall we from the primary care start SSRI for adolescents with regards to risk of suicide in adolescents with SSRI, or shall we refer to psychiatry department?
Oh, okay, adolescent is a special population. Okay, you must tune in when Prof. Aili talk about adolescent in the coming webinars. I don't know which webinar is that, but Professor Aili Hayanim Hashim is the person you want to talk about adolescent. But if you ask me, okay, there is a role of antidepressant. There is a role of antidepressant prescription for adolescents who are having depression or anxiety disorder. But for depression and anxiety disorder, which is severe, okay, and the prescription must be careful. The medication must be carefully prescribed and carefully monitored. That's all I can say.
Okay, thank you very much, Dr. Fazli. A lot of questions have been answered, but I'm sure there are a lot more to come actually if I allow them to ask further. But in 1 minute, can you give your final advice to the primary care doctors in managing anxiety and depression in the primary care setting?
Depression and anxiety is common, okay, and they can come to you with vague complaints, okay, that may not yield any positive results from the investigation that you send, be it blood or radiological investigation. And I would advocate primary care doctors to embark on the screening questions or screening questionnaire pertaining to depression and anxiety. Okay, and I would say that you all can manage mild and even moderate depression and anxiety by using the medications, the SSRI, okay, because it is safe, okay, and by combining the medication with simple modifiable cognitive CBT based intervention. And these simple non-pharmacological interventions, okay, are short and can be done in primary care clinic. That is my 1 minute of advice.
Very concise and very powerful indeed. Yeah. Well, thank you again, Dr. Fazli, for answering those questions and for the great presentation and the great advice. Yeah. It was a pleasure to have you with us. And this concludes the webinar. Thank you all for participating, for attending. We hope you have learned and enjoyed this presentation. Thank you again.